Good morning. My name is Joan Ostashkevich. I'd like to welcome you to this workshop called Complex Patients in Complex Organisations, Implications for Continence Care for People with Faecal Incontinence Living in Nursing Homes. This is an hour session and we have a lineup of 4 of us. The aim of this workshop is to share findings from qualitative and quantitative research highlighting the complexity of the global problem of faecal incontinence in nursing homes and to propose a person-centred nursing approach to care that goes beyond the cure paradigm, not the care paradigm. Dr. Lene Blekken holds the position of Associate Professor and Registered Nurse, and she's an academic also at Norwegian University of Science and Technology in the Department of Public Health and Nursing. Her PhD focused on the epidemiology of faecal incontinence and the development of an implementation strategy for improving continence care in nursing homes. She has educational and teaching competence in health assessment and physical examination, evidence-based practice, knowledge translation, and change in organisations and innovations in healthcare.
Persons living in nursing homes are the most fragile of the older patients. A frail older person is defined as those over the age of 65 with a clinical presentation or phenotype combining impaired physical activity, balance, muscle strength, motor processing, cognition, nutrition, and endurance, including the feeling of fatigue and exhaustion. In addition to these phenotype criteria, many of the patients also have comorbidities and disabilities. Altogether, this leads to a kind of double complexity in the patient group for the health personnel to manage. The individual patients have their unique, complex health condition, leading to a wide diversity of actual or potential health problems. The complex health condition among the individual patients makes the nursing home population a multifaceted group of patients with a complex set of care needs. One of the consequences is that the traditional unidimensional care pathways are not effective in this group. Because of the more or less complex health conditions, fecal incontinence is often caused by an interplay of interdependent factors in the individual patient. As health personnel, you will not succeed in your management if you offer the same treatment to the whole group. In the process of managing fecal incontinence, it is necessary to have a broad approach. And it is important that the health personnel have high knowledge and advanced skills when it comes to meeting patients' need for assessment, care, and treatment. The management of fecal incontinence must begin with an active case finding, including a thorough bowel assessment. The assessment leads to a determination on onset, cause, and type of fecal incontinence. It is important to remember that in older, frail persons, the causes are often multiple. For example, it can be diarrhea, impaired cognition, and toileting self-care deficit. The management must then be coherent with the causes in order to match the treatment to the individual patient. The exemplar guideline shown in this slide and the 2 next was developed in our research group and work as a checklist facilitating individualized assessment and management of fecal incontinence in patients living in nursing homes. The guideline is published in the book Management of Fecal Incontinence for the Advanced Practice Nurse, edited by Donna Bliss. The exemplar guideline is presented in the chapter Management of Fecal Incontinence in Frail Older Adults in Long-Term Care. The guideline starts out with information on top saying the assessment leads to a determination on onset, cause and type of fecal incontinence, frequency of episodes and any related change in bowel function and stool consistency. The assessment lays the foundation for nursing diagnosis and choice of interventions. The heading also reminds the user about the fact that in older people the causes are often multiple. According to what Susan will say later, many of the risk factors or correlates for fecal incontinence are modifiable. And those modifiable causes, you will find them on this list of potential causes and risk factors. And as said earlier, the management must be coherent with the causes in order to match the treatment to the patient. Even though this guideline facilitates an individualized assessment of patients in nursing homes, the proposals for management need to be further individualized. For example, the guideline may facilitate the individualized nursing diagnosis, for instance, fecal incontinence related to loose stools, possibly due to excessive laxatives, urgency, and reduced mobility. The guideline suggests several interventions related to this diagnosis. For instance, offer toilet assistance as appropriate and administer laxatives as appropriate. What appropriate is in the individual patients demands knowledge, clinical reasoning skills among care personnel, and contextually situated decision-making. One of the most important issues to secure proper diagnosing and management of fecal incontinence in the frail patients in nursing homes is for care personnel to acknowledge and be aware of the problem of fecal incontinence compassionately and initiate the assessment and discussions of fecal incontinence symptoms. And also, as this guideline facilitates, inquire patients or proxies about beliefs, goals, and preferences for continence care. In nursing homes with a high prevalence of cognitive impairment, patients are even more dependent of the care personnel to be aware of the problem and to be informed that fecal incontinence can be managed in many patients and about the options for management. In addition to discussing management options, it is also important to include the patient's proxies in the goal-setting process. In the consideration of goals of care, healthcare personnel should consider the degree of bother to the frail older person, whether a patient is all able to adhere to the interventions due to, for instance, cognitive or functional impairment, and the overall prognosis and life expectancy. As patients living in nursing homes to a large degree are dependent on care personnel to carry out the interventions, you also need to consider what is possible for care personnel to accomplish. As you see in this box taken out from the guideline, potential outcomes to consider are independent continence, controlled continence, contained continence, recognition, use of toilet, minimizations of leakage, improvement of symptoms, skin integrity, comfort, minimizations of distress, and dignity, where the goal dignity can be considered an overall goal for care. I know that my colleague Joan will talk about dignity as a goal later. For most of the frail patients living in nursing homes, fecal incontinence will be only one of several interdependent health problems, and the nurse will be only one of the professions involved in the care process. In order to capture a holistic picture of the patient, the approach needs to involve more than looking for fecal incontinence. One possible response for capturing the whole complexity of the person is comprehensive geriatric assessment, defined as a multidisciplinary diagnostic process related to intended to determine a frail older person's medical, psychosocial, and functional capabilities and limitations in order to develop an overall plan for treatment and long-term follow-up working towards person-centered goals. Identifying geriatric conditions by performing a geriatric assessment can help clinicians manage these conditions and prevent or delay their complications. And then what? Is it as simple as to tell the individual healthcare personnel working inside a complex organization just to do it? In most cases, probably not. And now I will give the word to two of my colleagues who will discuss these questions. But probably, maybe Susan will go first, no? No. Thank you for your attention.